In this presentation, we're going to talk about some of the interventions for coronary artery disease and for an acute MI. One of the first things that I always like to talk to you about is the PTCA. So, in the last module, we talked about revascularization procedures. A PTCA is an example of a revascularization procedure. PTCA stands for percutaneous transluminal coronary angioplasty. Essentially, what happens in a PTCA is the cardiologist will try to go in and open up the vessel as much as they can. They try for 90% if possible. However, what happens here in a PTCA is there's a small percentage of restenosis in 24 hours. And so what they follow up with is they like to make sure that they're on blood thinners. Typically we give a heparin and a glycoprotein inhibitor, such as, in practice you probably have seen integralin or ReaPro probably hanging, because you give it IV and it's going to hang for several hours after the procedure. Now for long-term maintenance after someone has a PTCA, they are going to be on antiplatelets, usually a combination of Plavix and aspirin for at least 6 months following the procedure. But I have this great little picture right here I want to kind of go over with. So in a PTCA, what they do is they go in through a heart catheterization, because remember, a heart catheterization is just a procedure to diagnose any type of blockages or cardiac issues that the individual might be having. So in this person's circumstance right here, they found some blockages and they're going to need to fix those blockages. And so what they're going to do, or what the cardiologist has decided to do, is he's going to do a PTCA. So he takes a sheath and guides it in through a main artery, and on the end of it has a little balloon. And so what he does is he takes this, right here my mouse is, this yellow stuff, this is the plaque. And so he threads this balloon through the vessel, through that plaque, into the other end, to where about the middle of the balloon is in the middle area of the plaque. And what he does is he rapidly inflates and deflates this balloon. And the premise behind that is, as he's rapidly inflating and deflating the balloon, the remaining plaque is going to go back up into the wall of the vessel. And so this area right here is going to be opened up. Remember I told you we try and get it 90%. And so it's opened up, and so what can happen now is blood can flow through here. So we want to keep this vessel open, and so that's why we have them on antiplatelets following the procedure. We do IV, like I said, integralin, ReaPro, heparin, and then we make sure they're on 6 months of Plavix and aspirin. Now, as I told you, sometimes a small amount of restenosis does occur. Well, a lot of times what a cardiologist will do to prevent this restenosis, he will place a stent. We call it an intercoronary stent. But the purpose of this is, once they have got the plaque back up into the vessel walls, they're going to leave this stent in here. And what this stent does is this stent ensures that this vessel is going to remain open. So a lot of times they will do a PTCA with a stent placement, and that's the purpose of that stent. So realize they're doing this through a cardiac catheterization. This is the intervention part that we had them sign the consent for, because this is an intervention to try and open up those vessels. So what you need to make sure of is, remember, your pre-op is all the same as it was for a cardiac catheterization, because they are going down to the cath lab and they're going to have the same procedure. So remember, you want to see what your CBC is. You want to see what your PT and your PTT. You want to go ahead and mark peripheral pulses, so you'll have that to check. One of the most important things, you want to make sure that they don't have an iodine allergy, a shellfish allergy, anything with that, because remember, they use a contrast media when they are doing this. The other thing you want to make sure and check is, what's their BUN and creatinine. If they have an elevated BUN and creatinine, then that tells you that they have a poor kidney perfusion, and what that means for you is that you need to call the cardiologist and the cath lab and let them know, because that means that we use nephrotoxic dye. It's going to stay in the kidneys longer. We don't want that. We need to protect the kidneys. So all those things that you do pre-op for a heart catheterization, you do the same thing for a PTCA. Okay? Post-op, Your post-op is going to be exactly the same as it is for a cardiac catheterization. When they come back to the unit, they are going to be on frequent vital signs. You're going to want to do frequent site checks wherever they went in at for this procedure. You want to follow your hospital's policy and procedures as far as frequent vital signs. You better watch your site for any type of bleeding. Also watch for any type of hypotension. You want to watch and make sure that their lungs were nice and clear and that they remain clear. The other thing is you want to assess for any type of chest pain, because in someone who's had a PTCA, if they start developing chest pain, typically what that tells us is there's some restenosis, or there's reocclusion of that vessel, and so we got to go back in there and open it up. But again, this is just one of those interventions that they do for someone who has a blockage. Now, these things I talked about, to make better sense for you, this right here is a great video to watch. You can either click on here on your handout PowerPoint, or I have put this video along with a lot of other great resources about acute MIs and CAD and interventions under the Module B tab. It's under the folder called Resources for Acute MI. So please take some time and watch this, because I talk about it, but once you see it, it makes so much better sense to you. And the neat thing when you watch this video, you will see prior to the PTCA how occluded that artery in the heart was. But then after they did the PTCA and they placed a stent, you see how wide and open that vessel is. And so that's what we can do now with someone who has any type of blockage. So please take some time and watch that video. Now, there are a lot of interventions for plaque buildup, for clogged arteries, and I can't say that one is necessarily better than the other, but what happens is the reason we have all these different procedures, it depends on the patient's overall clinical picture, and it also depends on what the cardiologist prefers. Another thing that we can use, instead of PTA, we have something we call a directional coronary atherectomy. So essentially what we do here is we go into the clogged vessel and we actually resection and we retrieve the plaque and get rid of it. So we kind of just shave the plaque away. And on the back of this right here where my arrow is, there's a little chamber right here, and as this little tool shaves it away, it sucks back up into this little vacuum container, because you don't want loose plaque going out into the circulatory system, because again, remember, that puts your person at an increased risk for some type of thrombus formation somewhere else. So that's another intervention that we can do. We also have an angiojet. This is pretty cool. This to me looks like a really neat pressure washer, because essentially what happens in an angiojet, we use it to break up blood clots that again are causing either partial or full obstruction of the blood flow in an artery. So this little catheter right here, this little purple part, it has all these little holes in here. So what happens is after this is put into the vessel, it delivers a really high power saline solution. And so what that does, that saline solution or the saline jets, they create a very powerful vacuum within the vessel. So it actually breaks up the clot and it removes the clot pieces out through the catheter and into the pump. Okay, and you have like a little catch chamber. I couldn't put it all in the picture obviously, but you have a little catch chamber back here where all the broken up thrombus will go. Again, for this direct right here, and also for this angiojet, your post-op procedures are exactly the same as they are for a PTCA. Another intervention we like to do quite frequently, we do this up at Birmingham right now. We're not currently doing this at any of the facilities, local facilities here that I'm aware of, but it's called brachytherapy. So this is an option for patients who have developed restenosis and previously implanted stents in the coronary artery. What happens here is we actually deliver intracoronary radiation through a special heart cath procedure. And what happens here is this radiation therapy, it reduces the rate of stenosis within the stents in approximately anywhere from 30 to 50% of their patients. This is most beneficial to your diabetic patients. And so this is one goal that we have, or I should say this is one treatment that we have to try and prevent restenosis of any type of vessels in the heart. Realize though, when someone has cardiac disease and they have, let's say they have coronary artery disease, they have blocked vessels, and we've tried medications and medications didn't really work for them, and we've tried some of them more some of the least invasive procedures, such as your PTCA, your angiojet. We've tried some of those. We've put stent ins, and the stents keep getting reoccluded, or you're not able to stent the areas that need fixed. Well, then what we have to turn to at that point is something called CABG. So CABG stands for coronary artery bypass grafting. This is the most common type of cardiac surgery. What happens is during surgery, the occluded coronary arteries are bypassed with a patient's own venous or arterial blood vessels, or they could be replaced with synthetic grafts. So this is what we have to do when a percutaneous intervention is no longer an option. As you see in this picture right here, the little red vessel right here, this is the one that's blocked, okay? So what we do is we just take another, either a vein or an artery, and we attach it, and we just bypass that area. And so blood flow is now being reestablished down here where it needs to be reestablished, and so the area that needs the blood that contains all the oxygen is getting to it. Things you need to remember with CABG, we're going to talk about some pre and some post-op. Now, what I really need you to do is there are some great videos that I've posted, okay? These are the videos right here. So you need to go to the handout and you need to watch these videos because, again, it talks to you about a CABG and you actually see someone having open heart surgery, and it's just really cool to watch. But what I want you to get from it is some of the understanding of how a CABG works to bypass the patient's blocked vessels. And so we're going to talk about pre-op, I'm going to talk about post-op, but you need to watch the intra-op period and see what's actually occurring to this patient, and that will help you realize how unstable these patients are initially and how invasive this procedure is. When we talk about pre-op, when someone is going for open heart surgery, or CABG, however you want to refer to it, you're going to have to get consents, okay? Consents for the procedure, you're going to have to get blood consents. There's lots of consents you're going to have to do. You'll have a surgical checklist that you follow. But essentially in pre-op, you need to get a baseline because this is going to help in your plan of care when they return from surgery and getting them back to baseline. So we want to know what their H&H is. What are the red blood cells? What's their electrolytes? These are all things that we need to know. What's their PT and PTT? Remember, they're going into major surgery, and so we want to make sure that they're within defined limits there. We also do a chest X-ray, and that's just for a comparison, and then we will do an EKG. Again, the reason we like to do an EKG is that sometimes after this surgery, patients go into abnormal rhythms, or they go into dysrhythmias. Remember, AFib is the most common dysrhythmia that occurs after open heart surgery. And so we just kind of need a baseline because we want them, if you were normal sinus rhythm before you had CABG, we really want you to be normal sinus rhythm by the time you're discharged, those types of things. We also like to get a UA to rule out any type of infection, and we do Nair cultures. Typically what we check for with Nair cultures is MRSA is what we're looking for. And the reason we're looking for that is that's going to alter their care a little bit. We're going to need to take care of that MRSA infection along with anything else they have going on. We also have to make sure they are prepped appropriately. Remember, we don't shave people anymore. We use the clippers. So they don't really get to keep a whole lot of hair. They get to keep the hair on top of their head and their eyebrows. All the rest of the hair has to go. And the reason that is they're going to have multiple invasive lines. They're going to have multiple incisions with sutures and all of these tubes coming in and out of them. And so they're going to have a lot of potential areas of contamination, and we do not want any hair there. And so that is why we we prep off, we clip off all of the hair. The other thing you want to make sure and do is you want to get a weight on this person before they go to surgery. And the reason that is during surgery, we have to replace a lot of their blood with fluid. And so it is very common for them in their post-op to have gained anywhere from 10 to 12 pounds just from the surgery. However, our goal is by discharge, they're back to their pre-op weight. So we really need to know what their pre-op weight is, because that helps us also direct the diuretic therapy that the healthcare provider will be ordering on this individual. Also during the pre-op time, that's when you want to do all your teaching. So I always say when you are teaching, it is best if that individual has someone else there with them, because think about it, you are giving lots and lots of information to an individual who's going to have a major procedure. They're not going to retain all that material that you're presenting to them. So hopefully if you present to them and one of their care providers, that between the two of them, they're going to remember the most of it. Things you want to make sure and cover in your pre-op about post-op. You want to kind of tell them what they can expect their day-to-day. So for example, like the first 12 to 24 hours, they'll be in the unit. After that, if they're considered a little bit more stable, then they will go to a progressive step-down unit, and then there they will stay there typically until discharge. So you want to let them know that. You also want to talk to them about what they can expect, what their loved ones can expect when they come to see them, because when they first come back from surgery, again, most of them are on a ventilator, and most of these patients have lots and lots of different tubes, and so it can be very shocking to some people to see their loved one that way. So you want to make sure and prepare them for that. You also talk to them about their medications. Remember, a lot of these individuals are on a lot of cardiac medications that try and treat their CAD. Well, we're actually going in there and bypassing the clogged arteries. So when they come back, they're not going to be on as many medicines. And so you want to make sure and reiterate that, you know, your medicines are probably going to change after this. Just bear with us. It's kind of a process we have to work with. I also let them know about pain, okay? So they're having open heart surgery. It is going to hurt, guys. And there's no way you can't not be honest about that. However, what you want to make sure and do is you want to make sure and tell them that we are going to be able to control their pain medicine so it's not going to interfere with the healing process. Okay? So you want to make a pain goal and be honest with your patient. A pain goal of a 0 is not really realistic for this situation. And what I like to tell my patients when they come in and we're doing the pre-op stuff, I will tell them, I said, I can't get you to a 0, but what I can do, I can get it to a toothache. And that's very relatable to most people. I have found most people, when you're trying to educate and connect, if you can find a story or common ground, it works much better, because everybody has had a toothache before. And with a toothache, remember, it's there and you notice it, but it's not so horrible that you can't do what you need to do. And so that's what we like to talk to them about. We like to talk to them about pain control, the fact that they will be on pain medicine around the clock for here, and they're going to need to continue on with that. A lot of your individuals, especially your older individuals, they are very worried about getting hooked on narcotics. And so a lot of times you have to make sure and you educate them on the fact of, if you are truly hurting and you take this medication, then you're not going to get addicted to it. That's not how it works. And so you got to make sure and explain that to them, because we know that when someone's in pain, it impairs their healing. It also can contribute to the development of pneumonia, because you're hurting, you're not really breathing, you're not expanding those lungs, you're sure enough not going to use your incentive spirometer. So you want to talk about all of these things pre-op so that they have very clear expectations following their surgery. And you also have to be realistic with them about the timeline for recuperating. For some reason, a lot of people think they're going to come in, they're going to have open up surgery, and they're going to be better in 2 to 3 weeks. And that's not necessarily true. Remember, this is a major procedure, one of the most major procedures an individual can have. So it's going to take them a while to get back to where they need to be. And you just have to be honest with that. Depending on their age of when they're having this procedure, it might impact their ability to be able to work. They're not going to be able to drive until they're cleared by the cardiologist and the CV surgeon. And the CV surgeon typically does not see them anywhere from 4 to 6 weeks following this surgery. So during that time, they can't drive. But think about it. For the majority of these people, they have gone in and they have opened up their chest. So their chest is now held together by wires. Imagine if that individual was in an accident. They would have a lot of trauma from that. So you want to make sure and explain all of this. The other thing is they're going to tire very easily, and let them know that's all part of the healing process, and that yes, eventually they're going to get back or even exceed what their tolerance or their activity level prior to surgery. It's just going to take time. And you can't really put a timeline on it. You can't say you'll be ready to go in 6 weeks or even 8 weeks. It's very individualized, and so you just need to let them know that up front so they can make a game plan, and they're not going to get discouraged because one of their biggest complaints is, I'm so tired, I always have to just take a nap. I've never had to take a nap before. But remember, their body is healing, and so you want to make sure that you educate them on that. Another thing that is very concerning for a lot of our individuals is, when are they able to be intimate with their partner again? Okay, and so you have to address that. And typically how we address that is we tell our patients, when you can walk up a flight of stairs without getting short of breath, then you're able to resume sexual activity. So again, that's something you need to talk to them about. You also want to talk to them about pets. Okay, a lot of people like for their animals to sleep in the bed with them or be up in the chair with them, and it's not that that's not a right thing to do. But what you have to realize is these people right now currently have open incisions, and so they don't need any animals around this. And so we have to educate on the fact that until you are completely healed up, you do not need an animal sleeping in the bed with you or sitting in the chair with you when you have your wound not covered. So you want to make sure and you address all that preoperatively so that they know it and whoever their caregiver knows it. And also they kind of know what to do when they come back from surgery. So again, this cabbage video, I really need you to watch it. It is under Module B, and it's labeled cabbage videos. Okay, so please make sure and watch that, because it makes the things I say pre-op and post-op, it makes so much more sense when you watch the videos. So post-op care. When they come back, remember they're going to CCU. Okay, they'll be in CCU anywhere from 12 to 24 hours, just depending on how the patient recovers from the procedure. They're going to be on a ventilator. They are going to have pacing wires. They're going to have an art line. They're going to have a transducer. They're going to have a Foley. They're going to have chest tubes. They're going to have multiple IVs. They're going to have lots and lots of tubes and wires, guys. Okay, they are. Remember, at this point in time, that patient is very, very unstable. Okay, and so they have to be monitored very frequently, and that's why they are in CCU. Some of the things you're going to see is we have pacing wires. Okay, so these pacing wires are connected to an external pacemaker. Things you want to make sure of with pacing wires, you want to make sure that the settings are what stay on whatever the physician ordered them to stay. Usually, pacing wires stay in till 1 to 2 days prior to discharge. And essentially what our pacing wires are, they're kind of our backup. Sometimes after surgery, our heart, it starts beating in a rhythm that is not normal. They start developing dysrhythmias, or they even start developing blocks. And so sometimes what we have to do is we have to help the heart out a little bit. And we'll put them on an external pacer with these pacing wires. And the neat thing about these pacing wires is these pacing wires, they really look like mini jumper cables. They have little metal prongs on the end of them, and they go into the external pacemaker. And the physician sets the settings on what he wants that patient's rate to be, and they maintain that. And so you want to make sure that they all the settings are correct and that it's taped securely to the individual's chest when they're not in use. Some other things you're going to see chest tubes, guys. Okay, so here's the thing with chest tubes. Your chest tubes are connected into suction, and the reason they are is because your patient typically has a lot of output. That first 24 hours, 24 or 48 hours, they have lots of output, okay, from their incisional drainage, from the drainage they have going on inside that you can't necessarily see. So what happens is, instead of that fluid accumulating in the chest cavity, they put chest tubes in them. And their purpose is to drain the fluid that was trapped in there. So things you want to make sure and do is you want to make sure there's no kinks in the tubing, that it's not cut up on the bed, nothing like that. You also want to make sure you monitor this very frequently. And if for some reason you start noticing a lot of output, and what I mean by a lot of output, if you see 150 mLs or more in 1 hour, you better be calling the doctor or the PA or whoever's taking care of that individual. You need to call them because something's not right. You should not be bleeding that much. And so that's what I always like to tell people as far as your rule of thumb of how much discharge or how much fluid is too much. Okay. Other things you're going to see they're going to have daily labs. Okay, and the reason they're having daily labs is we had to give them lots of fluid and it diluted a lot of their electrolytes. And so they are prone to have electrolyte imbalances. We want to make sure and check for those. It's very common in this population, especially your potassium and your magnesium. And again, that's due to the hemodilution during surgery and also the diuretic therapy. So you want to make sure that you talk about why are you giving this diuretic and things they need to watch out for, and the fact that that diuretic is going to make them lose fluid, and the way that is they're gonna urinate it out, and so you need to make sure that they're aware of that. Also, before you give diuretics, remember most of your diuretics are potassium wasting. So you need to know what is their potassium level. The other thing you want to make note of is what is their blood pressure, because if you are pulling fluid off someone, you can anticipate that their blood pressure is going to drop. So you need to know what your patient's baseline is so you know what to do about the blood pressure and watching the blood pressure while you're taking care of them. Other things we worry about, we do neuro checks Q1 hour for the first 24 hours. Okay, and the reason that is because sometimes this population will have a thrombus formation, and that thrombus, depending on where it goes, if it goes to the brain, they could have a stroke. Okay, so we're making sure we're doing frequent neuro checks. What's their level of consciousness, those types of things. Bleeding is also an issue, and so we are making sure we're checking all of our chest tubes, or checking all of our dressings and making note of any type of bleeding that they might be having. Other things we worry about post-op, we have to make sure and keep our patient normotensive. So what I mean by that is we worry about hypotension and hypertension. The reason we worry about hypotension in someone who's had a fresh post-op cabbage is because with hypotension, it can actually collapse the grafts. And that's not a good thing, guys. And so with hypertension can actually, they could blow out around the suture site. So they can either blow out some of the sutures, or they can have major leaking around the suture sites. So that leads to an increased risk of bleeding. And so that's how we want to make sure that we keep them very much in that normotensive range. So these are all things that you're going to watch for. Again, I might talk to you about dysrhythmia. The most common dysrhythmia is AFib. However, a lot of times they do develop blocks. So you want to make sure and keep an eye on their monitor and check, compare often to previous EKGs to see if any changes are occurring. Other things I like to talk about is your patient is at an increased risk for infection. The reason that is one, they've had major surgery, but also because they have numerous surgical sites. So in addition to keeping an eye on all the dressings, you want to keep an eye on all the surgical sites. Where we get the vein from is called a harvest site. So with a harvest site, the one we like to use the most is the saphenous vein. That's our favorite. We also like the internal mammary artery. That's the most often that's used for grafting. So the doctor typically uses internal mammary artery and then the saphenous vein. So the problem is if you are removing a vein, the saphenous vein from the leg, what's going to happen is that leg, it's not going to have as much blood perfusion to it. It's more prone to developing, to retaining fluid, so that leg tends to swell a little bit more than the other ones. This leg that has the saphenous vein removed, it also tends to be a little cooler than the other one. You might have more of a diminished pulse than the other one, and those are normal findings. And remember, I said cool, but not cold and dusky color. There's a difference. Just the circulation in that leg is not quite as good, and so when you compare leg to leg, there might be a little bit of a difference there. The other thing you have to worry about, remember I told you that they put on lots of fluid after a post-op cabbage. So look at this suture site, okay? You want to worry about dehiscence. So dehiscence essentially is just where the wound has opened back up. Well, if our wound or our surgical site opens back up, then that's a major source for potential infection. And so you really need to keep an eye on that. That's a lot of times all of these, your harvest sites, you do ChloraPrep. Now, we have something we call a long incision, and this is a great example of a long incision. Typically, it starts a little bit above the knee, and it goes a little bit below the knee. Okay, so this is a long incision, and this is why we worry about dehiscence, because it is so long. We now like to use something, we call it a short incision. So essentially what happens, and we'll look over here, this picture A, and I'll kind of show you. The PA, or the physician, they make a small incision up near the groin, and they clip the saphenous vein here. They make a very small incision down right below the knee, and they pull out the saphenous vein there. So those two little sites where they retrieved the vein from, they close it with dermabond, and then what's so great about that is you have less likelihood of dehiscence, you have less likelihood of a development of infection versus this long incision right here. So that's something you want to think about. And you might say, well, if this short incision is better, then why are we still doing this long incision? Well, sometimes we have to do the long incision, especially on people that have peripheral vascular disease. Because remember, people that have peripheral vascular disease, they have very small vessels, okay? And so, or it could be this person is a diabetic, because a diabetic, they tend to have smaller vessels, more fragile vessels. Or it could be that just this, the patient is just obese, and it's very hard to get to the vein with this manner, and so they actually had to open it up. So there's lots of reasons why we still have this long incision around, and those are just a few that I provided you with. But you want to make sure that you keep an eye on these surgical sites. The other thing I like to talk to you about, the mid-sternal incision, different physicians like different coverings, okay? But what you need to be aware of is you got to follow your hospital's policy on whatever type of dressing they have in place. Some of them stay in place 4 or 5 days. Others stay in place 7 days. So you need to make sure and make note of that. Also, if they are going home before that 7-day mark, if they have a 7-day dressing, you need to educate the individual on how to do post-op wound care, what they should be expecting and what they should be looking for. As I talked to you about in harvest sites, complications are infection dehiscence. I love this example right here because this lady right here, she developed an infection in the bone, okay, after she had open heart surgery. And so actually had to go in there and remove her sternum right here, okay. Then she developed an infection and we had to have her moved back. So it was just a super long process for this lady right here that had this this complication. So you really just have to be careful. One thing that contributed to this in this instance, this lady had larger breasts. We do not like anything around the the suture sites or the incision. However, with people that have larger breasts, think about gravity is not their friend, and so the larger breast, it tends to pull more on the incision. And so what we do to alleviate that for individuals with large breasts, we like for them to wear some type of support device, usually a sports bra that hooks in the front that they're able to hook up. And so that's kind of what we do for patients that have larger breasts, because we realize that they still need some form of support there. Other things that are likely to happen in someone who's had CABG, pleural effusions, they are common. A lot of times they're caused from pulling the chest tubes too early. Sometimes pleural effusions, or I should say the majority of pleural effusions in someone who's had CABG, they clear up on their own. We just keep an eye on it. We might have to give them some supplemental oxygen, but they do tend to clear up on their own. So that's one thing. Another thing that can occur is the cardiac tamponade. So with this right here, you remember you want to make sure and keep a check on their blood pressure. You also want to follow up on any distant heart sounds that you see, or if you see any type of distended neck veins, because those are all signs of that. Remember that Beck's triad. So you want to make sure and keep an eye on that. Your traditional CABG, they actually open you up. They open up your sternum. However, we now have open heart surgery that you don't have to, or I should say you have minimally invasive. So this is a great example of a minimally invasive. So what they do here is there's no thoracic incision. What they do is they just make a 2-inch incision in the left side, the left rib, or I should say in the rib on the left side, the second one. And what they do is they remove part of that rib, they go to the blocked artery, and they bypass that blocked artery. So this is wonderful. However, this minimally invasive, it is only for patients that have a blockage in the left anterior descending artery. That's it. So if your blockage is somewhere else, then this is not a procedure that you're a candidate for. This one I like to talk about right here. This is called an off-pump open heart surgery, and what happens here is with CABG, we put them on the cardiopulmonary bypass machine. Okay, that's the machine that does the work of the heart while the physician is working on the heart. And when you watch the video, you see how they have actually stopped the heart. So that's your traditional. Well, what we found was if they could do this off pump, meaning they're not going to be on the cardiopulmonary bypass machine, our patients had much better outcomes. They had shorter hospital stays, they had a decrease in mortality rate, infection, and also in cost. So we like to do these. What they do is they use this clamp right here that you see. This clamp is called an octopus clamp. So what it does is it just stabilizes the area of the heart that the physician is actually working on. And so I found this YouTube video about it, and it's pretty cool. Remember, the heart's beating the whole time he's doing the surgery. The heart is beating, and so it's just really neat to watch, and you get to see. For someone to do off pump, they have to be a very skilled CV surgeon, okay, and they also have to be really fast, because remember, the heart's beating the entire time. So I think we have 2 physicians locally, or I should say CV surgeons locally, that will do the off pump, but we still have a lot of physicians that don't. And you just have to realize it's a skill set, okay, and not every CV surgeon has that in their little toolbox. Like they talked about 1 or 3, the little toolbox, and you pull out the tool you need. Not every CV surgeon has been trained in doing off-pump coronary artery bypass. So this is another just great example of what modern technology has brought to the table as far as taking care of patients that have CAD.